Thank you for your kind introduction. Good morning. I'm Jin Young-kwak from Yonsei College of Medicine, Severance Hospital, South Korea. Today, I'm going to talk about artificial intelligence and thyroid disease. These are my learning objectives. Prior to getting into the role of AI in the thyroid ultrasound, I would like to talk about its applications in radiology. I will show you some examples. This is a list of chest X-rays scheduled for interpreting at our hospital's parks on March 21st. With so many images, it can be difficult to decide which one to interpret first. AI can be used to prioritize the readings based on how serious the illness is. A 68-year-old woman with a family history of breast cancer took screening mammography. Two radiologists read that there was no suspicious findings on mammography. However, AI indicated that there was something wrong here. A small cancer was detected on ultrasound. This lesion was compatible with the site where the AI indicated there was an abnormality. Unlike its application in determining the severity of an illness while finding lesions in images like chest X-rays or mammographies, AI is solely utilized in thyroid ultrasound to classify benign and malignant lesions captured by the ultrasound performance. Now, let's look at the benefits of thyroid AI for diagnosis. In the 2000s, CAS in a variety of sectors were built using machine learning, but they were not widely used because to poor performance. In the 2010s, CAD was developed using deep learning and has proven to be quite effective. Thus, the CAD discussed in my talk today are deep learning-based ones. There are several AI tools for evaluation of thyroid nodules on ultrasound. The two commercial AI tools listed above were the most often used and studied. AI tools' diagnostic performance may be separated into two categories: comparisons with doctors alone and comparisons with doctors with AI support. This table shows the AUC or accuracy of the AI tools and doctors. Many studies showed that doctors had better diagnostic performance than AI. But these two studies had that AI had better diagnostic performance than doctors. In the study by Wei et al., the diagnostic performance was either better or worse than AI, depending on the clinician. In the study of Zhang et al., experienced doctors outperformed AI in diagnostics, whereas residents and fellows underperformed. Based on prior research, we can infer that commercialized AI tools have the potential to benefit less experienced doctors. Let us compare the diagnostic performance of a doctor's judgment alone to that with AI support. This table shows that using the AMCAT enhanced diagnostic performance for diagnosing a thyroid nodule, regardless of the doctor's level of experience. The S-Detect also improved diagnostic performance. However, with the assistance of AI, diagnostic performance can decrease. Let us focus on non-commercialized AI tools. Sufficient data is the most crucial requirement for developing AI solutions. An AI tool called Thyroid was developed in China using over 18,000 images to train. The Thyroid Assist strategy improved the pooled AUC of the radiologist. My research team developed SERA using about 14,000 ultrasound images in 2020. SERA assistance improved the diagnostic performance of less experienced doctors in ultrasound. This study investigated the diagnostic outcomes of 5 clinicians with modest experience with thyroid ultrasound when they got SERA support. 3 of them increased their diagnostic accuracy with SERA assistance. The AI assistance had no effect on one doctor's diagnostic performance. In addition, AI worsened one doctor's diagnostic outcomes. If you're concerned about integrating AI tools into clinical workflows, you should consider the possibility of post-deployment underperformance. As you know, ultrasound is an operator-dependent tool. Therefore, not all ultrasound performers get the same ultrasound images. The ultrasound images represent the operator's knowledge and experience. As far as I know, all studies on AI tools have used static images for diagnosing thyroid nodules on ultrasound. There is no research using AI tools after each operator performed ultrasound for the same nodule. These are images of the same nodule examined by ultrasound novice and expert, respectively. The images taken by a novice have suspicious ultrasound features. On the contrary, the images taken by the expert appear to be cystic, benign nodules. Despite the same nodule, Sarah produced different outcomes because the taken images were different. To find out the usefulness of AI tools by doing ultrasound on each of the same nodules, we did a prospective study by doctors with different experiences. Following a real-time ultrasound, the third nodule was marked as either 1 or 0, depending on whether it was judged to be cancer or not. After that, the seller value was determined using his or her own ultrasound image. After confirming the seller value, the final evaluation of the nodule was done. Beginner's final decision changed from 18.6% after checking the seller value, but an expert final decision changed from only 4.2%. Ultrasound was done for the same nodule, but the theta value differed depending on the image left by the ultrasound operator. The AUC of theta alone was higher for an expert than for beginners. Theta was helpful only to beginners. I will show you some cases. This nodule was diagnosed as benign on ultrasound. The Theta value suggested cancer. By combining the Theta value with the ultrasound image, the margin analysis and final judgment were revised. In surgery, the nodule was found to be cancer. This nodule was diagnosed as benign on ultrasound. The Theta value was high. By combining the Theta value with the ultrasound image, several lexicon analysis and final judgment were revised. The nodule was confirmed as cancer in surgery. Let's get to the second learning objective. I will make a presentation with 3 subheadings. On ultrasound, some neck lesions may be misdiagnosed as third nodule. From an outside clinic, all 3 nodules above were read as third nodules, and the bottom one was referred because of suspected recurrence at the operation site. These were all confirmed as esophageal diverticula. As seen in the situations above, AI tools are more likely to provide confidence in an incorrect diagnosis if the doctor thinks the lesions are third nodules. The doctor's knowledge and experience can impact the ultrasound image taken. This patient was referred due to a third nodule with macro calcification. Do you all agree? I didn't agree. I left 2 ultrasound images that clearly showed the disease. Can you see the ring down artifact? The artifact can be seen from air. The lesion was confirmed as a preform sinus fistula. In this case, The current AI tools trained specifically for the diagnosis of thyroid nodules can be ineffective. This patient was referred to the FNA at a suspicious thyroid nodule. Before doing FNA, I found ultrasound images performed 3 years ago. Benign thyroid nodules may undergo mummification over time. It may occur spontaneously or result from FNA, ethanol ovulation, or RFA. Ultrasound features can be overlapped with a thyroid cancer. Of course, AI values are meaningless in this case. Therefore, it is important to constantly compare the current image to the preceding one. Sometimes surrounding structures can be mistaken for a thyroid nodule. This patient was suspected of having a thyroid cancer and was referred for FNA. Its size was measured. The value was so high. The images taken on the transverse and longitudinal scan showed the different structures. This is thyroid cartilage and this is cricoid cartilage. This part is the cricoid cartilage seen on the transverse scan. In summary, the performance of AI tools may be comparable to that of experienced physicians. Especially, it can assist less experienced doctors to diagnose a thyroid nodule on ultrasound. AI can benefit many doctors, but not all of them. Sometimes, AI outcomes can be confusing. Before incorporating AI into clinical practice, a thorough evaluation is necessary. Let's move on to the final learning objective. I'll now show you several studies that use AI to predict the risk of thyroid cancer and molecular factors. AI is a computing technology capable of imitating or surpassing human intelligence, which includes all of these parts. As you know, thyroid nodules are very common in adults. As a result of screening ultrasound, we can find clinically insignificant thyroid cancers, as well as many benign nodules. Stopping the screening ultrasound appears almost impossible. Therefore, I believe it's time to focus our efforts on identifying a clinically significant thyroid cancer. Let's look at several studies on AI as a prognostic factor. In addition to the clinical factors that have been identified so far, there are investigations of molecular or imaging biomarkers. The ATA already utilized the molecular factors for risk stratification at a thyroid cancer. When molecular profiling is undertaken, it is done at one location and is prone to sample errors. This approach may not accurately represent tumor heterogeneity. Imaging biomarkers, on the other hand, may be more representative of nodules than molecular biomarkers are. The development of imaging biomarkers begins with the assumption that the phenotype is related to prognosis. Korean researchers have been particularly interested in this topic. Investigations have found that cancer with suspicious ultrasound features had a worse prognosis. All analyses in these studies were performed using the traditional human being visual assessment. Therefore, there was a fatal weakness of lack of objectivity and reproducibility. These studies have demonstrated that objective radiomic features or AI tools can be utilized as an imaging biomarkers to predict lymph node metastasis, recurrence, or molecular status in thyroid tumor patients. For a long time, the question has arisen as to the molecular biological mechanisms that lead to the characteristic ultrasound features of thyroid cancers. Recently, we investigated the relationship between the morphological features of the cancer and molecular mechanisms. In this study, individual suspicious ultrasound features consistently suggested an upregulation of genes related to immune response and epithelial mesenchymal transition. And GSEA presents gene sets enriched in PTCs assessed as positive by CAT. So, we concluded ultrasound features assessed by radiologists at deep learning-based CAT revealed molecular biological features and tumor microenvironment in PTCs. To speculate thoroughly AI, there is still both optimism and concern about the implementation of AI tools to help diagnose the thyroid nodules on ultrasound. The possibility of AI adoption in everyday clinical practice should be evaluated through transparency in AI implementation and scientific validation. Radiogenomics may be a game changer to decide on action and numerous thyroid nodules. Before finishing my talk, I will introduce Sarah shortly. You can use Sarah without charge after the developer has certified it. Thank you for your attention.